Foot drop is not a disease, but a term to describe the difficulty lifting up the front part of your foot. If you have foot drop, you may find the front part of your foot drag on the ground when you walk. Foot drop does not only happen among stroke and neuro patients. However, foot drop among stroke and neuro patients tends to get a lot more complicated due to many underlying reasons. For example, multiple neuro deficit, excessive bed rest, lack of range of motion exercises, and many of the times, poor rehab strategy in managing their foot drop. I understand that many of you can't wait to learn new exercises to improve your condition. However, it is also very important for you to do the right exercises that target the root causes of your impairments too. So in this video, I will be sharing the 5 major root causes of foot drop to help my viewers and my patients to have a better understanding of foot drop and subsequently improve their foot drop management. My name is Gan, physiotherapist from the Rehab Studio. The 5 major root causes of foot drop are: the first one, the paralysis or weakness of dorsiflexors. Second, contracture or shortening of the plantar flexors. Third, spasticity or rigidity of the plantar flexors. Number 4, hyperreflexia with anxiety. And the last one, altered muscle synergy. Let's start off with the paralysis or the weakness of the dorsiflexors. Dorsiflexors are a group of muscles that lift up the front part of your foot. Any damage to the nerve pathway supplying dorsiflexors can result in paralysis or weakness of the dorsiflexors. For example, a nerve injury, a spinal cord injury, or a stroke. Not everyone with a foot drop have underlying dorsiflexors paralysis or weakness. The dorsiflexors can still be functional but unable to generate enough forces to overcome the other root causes like muscle contracture, muscle shortening, rigidity or spasticity. However, in long term, the dorsiflexors are usually weakened due to underuse. To assess if you still have a good control over your dorsiflexors, put your fingers along the dorsiflexors. Try to lift up the front part of your foot. Observe for an uplifting angle or the toes, and feel for any movement of the dorsiflexor muscles, starting from the dorsal part of your foot up to the outer part of your shin. Any curling of the toes, downward or inward pointing of the ankles, or flexing of the knee are considered as a compensation and is not a positive result. One thing to note during the assessment is that this is not a yes or no question. It is rather a range of how severe are the root causes. It is very likely that you have more than one root causes with different severity to your foot drop. Next, I will talk about muscle contracture or muscle shortening of the plantar flexors. Muscle shortening and muscle contracture are very common among stroke and neuro patients who have limited mobility. While muscle shortening is reversible, muscle contracture is not and requires a surgical release. To assess for muscle contracture or muscle shortening, you will need another person to perform the assessment for you. When you are at rest, lying face up with your affected leg extended, someone else will need to move your ankle from a downward pointing position to the upward pointing position of at least 100 degrees. You can only be considered as free from muscle shortening or contracture if your ankle can be moved within this functional range. If the movement is not possible at all, you are likely suffering from muscle contracture, muscle rigidity, muscle spasticity, or the combination of these. While muscle contracture or muscle shortening does not necessarily mean spasticity or rigidity, there is no need to differentiate muscle contracture or muscle shortening away from spasticity or rigidity because patients with rigidity or spasticity should be treated as they have underlying muscle shortening as well. Moving on to rigidity and spasticity. Rigidity and spasticity are involuntary muscle contraction that interfere with movement. Rigidity is commonly seen among patients with neurodegenerative disease, for example, Parkinson's disease or multiple system atrophy. On the other hand, spasticity is commonly seen in patients with stroke or spinal cord injury. If you have limited movement over multiple joints and involuntary muscle contraction that involve multiple muscle groups, you are very likely suffering from spasticity or rigidity. In addition to the 3 root causes which I have just explained, the following 2 root causes are relatively less well known and tend to be confused with spasticity. While they can be coexist with spasticity, different rehab strategies have to be in place to target each of these root causes. Hyperreflexia is a form of overactive body reflexes due to the lack of inhibition from the upper motor neuron, while spasticity is a form of hyperreflexia. Hyperreflexia does not necessarily mean spasticity. To differentiate these two, hyperreflexia foot drop with anxiety only happens in a specific situation that triggers the anxiety of the patient. If you find that for a similar task, your performance is better when you do it in a comfortable environment than in an environment that triggers your anxiety. For example, when your physiotherapist is standing next to you providing mental support, compared to while strangers looking at you while you are in a crowded environment, you are very likely suffering from hyperreflexia foot drop with anxiety. Lastly, the altered muscle synergy. A muscle synergy is the activation of a group of muscles that contribute to a particular movement. For stroke and neuro patients, their muscle synergy can be altered due to their underlying neural deficit. For example, muscle weakness, poor coordination, loss of sensation, and so on. Taking foot drop as an example, with a proper muscle synergy, our hip, knee, and dorsiflexors will work as a group to bring our leg forward when we walk. However, for a stroke or neuro patients, due to the underlying neural deficit, other muscles, usually the plantar flexors or the ankle inverters, will be activated instead of the dorsiflexors when you are trying to lift up your leg. Without proper correction and rehab strategy, there will form a new altered muscle synergy that worsen your foot drop. If you find that your ankles only actively pointing downward or pointing inward when you are trying to lift up your leg, but not when you are doing other tasks or when you are at rest, there is a possibility that you have underlying altered muscle synergy. And now I have done explaining the 5 major root causes of the foot drop. However, things are not always as clear-cut as we wish. Many of the stroke and neuro patients who I have seen have a combination of different root causes to their foot drop, which require different rehab strategies that target each of their root causes. However, it is also very important for you to understand which rehab exercises are targeting at which root causes to your problems, so that you do not waste time and resources on exercises and treatments that are potentially not beneficial to you. After sharing on the root causes of the foot drop, I will continue to produce videos sharing on home exercises for foot drop and also gadgets that are beneficial for foot drop. So if you enjoyed this video, please remember to subscribe to this channel and stay tuned for more videos to come. If you would like to arrange a physiotherapy session with me or my team members, feel free to drop us a call at our work number to arrange for a free tele-consultation. Thank you for watching these videos and see you in the upcoming videos.